Good evening, doctors. Welcome again. Today we are going to discuss about prolactinoma. See with this arrow here, this arrow represent prolactinoma, tumor of pituitary. Okay. Now let's discuss about hyperprolactinemia. Hyperprolactinemia is causes by adenoma or by drugs SSRI, antipsychotic, alpha methyl cocaine and metoclopramide. Hypothyroidism also a cause of hyperprolactinemia, mass effect and trauma. Let's discuss. What was happen in adenoma? It releases prolactin itself on anterior pituitary. We can identify adenoma by MRI image. Adenoma comprising optic chiasm. It causes visual field defect on lateral sides. Damage to pituitary stalk. What happens? Dopamine decreases and prolactin increases. Now, why SSRI responsible for increase in prolactin? Because selective serotonin reuptake inhibitor increase serotonin responsible for increase prolactin release, so prolactin increases. Antipsychotic inhibits dopamine, so there is increase in prolactin. Hope till here it's clear. Now, prolactin release hormone, serotonin increases, dopamine decreases and thyroid releasing hormone increases. So what happens when serotonin increases, prolactin increases, dopamine decreases, prolactin increases, TRH increases, thyroid releasing hormone increases, prolactin increases. Let's discuss. When thyroid releasing hormone increase from anterior pituitary, then TSH increases, but T3 and T4 decreases. So if T3 T4 decreases, it gives signal to hypothalamus that T3 T4 decreases, so they release thyroid releasing hormone more. Okay. In women we see microadenoma, and what are the features? Features is increased milk secretion, galactorrhea we can say, or amenorrhea because GnRH, growth releasing hormone, decreases, so not growth releasing, gonadotropin releasing hormone decreases, so they blocks LH and FSH, so there is amenorrhea or headache also. In case of male macroadenoma, we see gynecomastia, erectile dysfunction because it blocks gonadotropin releasing hormone, block LH, FSH and testosterone, so erectile dysfunction, decreased libido, bilateral hemianopsia or decreased testosterone, so there is no excess hair, lack of hair. Now best initial test for prolactin level is serum prolactin. The hyperprolactinemia is serum prolactin. Normal female prolactin is less than 35 nanogram per ml and in male is less than 15 nanogram per ml. Okay. In pregnancy, the level of prolactin is 35 to 386 nanogram per ml, or moderately elevated prolactin we can say 30 to 300 nanogram per ml. In case of macroadenoma, we can think more than 500. Or this is wrong statement, don't think on it. Okay, otherwise all right. Surgery, we can go for transsphenoidal first line or macro surgery within 6 months if medical treatment is not respond. If the macro adenoma, we can do sometime transsphenoidal surgery also. Microadenoma, we can go for transsphenoidal surgery. For macro surgery within 6 months if treatment is not responding. Medical treatment means medicines are not working, that time we need to go for it. Okay. Now the most accurate diagnosis for prolactinoma is MRI of brain, and treatment by dopamine agonist, D2 agonist like cabergoline, bromocriptine. Okay, so let's discuss the doses like 0.5 to 0.25 milligram cabergoline twice a weekly, 2 times in a week we can give. Maximum is 1 milligram twice weekly. In children and pregnancy, not recommended cabergoline. Adverse effect like GI upset, dizziness, fatigue, postural hypotension, dysmenorrhea, vision abnormality, rare fibrosis and valvulopathy. Now bromocriptine dose is 2.5 milligram, 2.5 milligram, or the brand name is Perladel. It's 1.25 to 2.5 mg, 2.5 to 15 mg, and not up to 30 mg we can give per day. And if this is not helpful, sometimes we can go for radio also, stereotactic radiotherapy, who well respond to medical treatment. So guys, I hope it's clear for you till here about prolactinoma. And that's all for today. If you have any queries, any question, you can ask me. And if you still not subscribe my channel, please subscribe it. Thank you, good day and goodbye.